Maybe we should go.
Maybe you should go with questions.
Yeah, that's
No.
a benefit for being here.
Or hints.
That'll show them, that's for sure.
Just a problem.
It's a good point.
Word for word, but just like,
I bet you will show up to every class after that.
You know, in here, I started doing formatives in here. Next year, depending upon our curriculum, we do formatives in Harvey Law because they can be in there too. You know, just to try, you know, the TBLs are trying to do something like that, but three-week three-week themes are not easy themes to learn. You know, enough stuff for the TBLs or for the final, to be honest with you. So that's a problem. Okay, so I've got this little issue this week and a couple weeks. I have to have cataract surgery. That's what you get from going to your ophthalmologist and saying, you know, I'm really not seeing very well with these glasses, and then they do this whole test. They says, well, you have cataracts. He said, so I have to do that. But depending upon how the recovery goes, if I can't lecture, I have a substitute. She's really good. She's worked with me before in this course when she started when she was a student. And that's Christina Wolf. Okay, Christina Wolf McGuire. And Christina also has an intense anatomy background. So if I can't do the lectures that I'm supposed to do, like on the second superficial phase, because this is going to do the first part today, and cranial nerve, she's going to fill in there. But she's also going to do, as a couple lectures of her own, she has a deep phase. Okay, she's very good. I think you'll like her. Okay, so hopefully they don't ruin my eyesight completely, but that's the problem with getting old. All right, so we're going to look at superficial face. We're actually going to talk about some things that we talked about upstairs in relationship to openings and things like that. Here, I'm putting this in front because we're going to be talking about really the sensory aspect of the superficial face. Now, the big nerve, cranial nerve, that deals with sensory innervation of the head is a trigeminal, okay? Obviously, you are going to learn it backwards and forwards from the standpoint of this is the nerve that, if nothing else, innervates the dentition from a sensory perspective. It innervates the palatal mucosa, the nasal mucosa. It innervates the cornea. It innervates muscles of mastication, which we've already talked about. But it's called trigeminal or three twins because it has three divisions. And the first division of this passes into a region through this superior orbital fissure, referred to as the ophthalmic division, or V sub 1, okay? The ophthalmic division of V sub 1. Now, what you have to, some of the stuff I tell you is really there to help you, whether you believe it or not, okay? All three of these divisions have branches, but all three of these divisions give off those branches in a different region. This branch we're going to see gives off its branches in the orbit where the eyeball is. Okay, we're actually going to have a lecture also on the orbit. But the second division, or the maxillary division, enters into the space called the pterygopalatine fossa, and that's where it gives off its branches. All V2 branches are given off in the pterygopalatine fossa. And then we've got the mandibular division, which lives in this space we alluded to this previously, called the infratemporal fossa. And the infratemporal fossa is where all of the branches of the third division, the mandibular division, or V sub 3, are given off. So we're going to pretty much center on branches associated with the trigeminal right now in regards to the first two branches, okay? Not completely with the second branch, but definitely completely with the first. Yes, did you have a question?
Yeah, can you just summarize, so it's the intertemporal fossa for the mandibular branch, the V sub 1 for the, which branch?
V sub 1 is the ophthalmic branch, first branch, V sub 1, and that branch is in the orbit, where the eyeball is. V sub 2, or the maxillary branch, enters into a space called the pterygopalatine fossa, and that's where all of its branches are given off. V sub 3, or the mandibular division, gives off all its branches in the intertemporal fossa. This is this deep space surrounded by muscles of mastication. All right. So there's a lot of things that pass through these regions that have relationships to one another, but the orbit is this area that's a lot more than just support of the eyeball. Okay. All right. So these are branches. These are branches of V sub 1, and V sub 2, and V sub 3. I think all three of them are listed here. Okay. So I've got here something we'll talk about more specifically with cranial nerves, okay, and spinal nerves as well. When we get to neuro first semester next year. Okay. Nerves trunks have a lot of processes that they carry. Some of those processes are motor. Some of those processes are sensory. Some of the motor processes are of two types. They either innervate skeletal muscle and are said to be somatic motor, or general somatic motor, or general somatic efferent, or they are visceral motor. The visceral motor branches are associated with the autonomic nervous system, because that's what the visceral motor system is. It's the autonomic nervous system. With sensory branches, we have also some differentiation into the types of sensations that we have. We have general sensations that are found throughout the body that are things like touch, pressure, pain, temperature, and proprioception, okay, or kinesthetic sensation, okay? Those are general sensations, okay? And then we have sensations that are visceral sensations that are coming back from visceral tubular organ systems, for example, coming back from bronchioles, okay? I'm almost done with my cough, but it's still there, okay? Coming back from like irritation of bronchioles, or things associated with innervation with the gut tube, or with the genitourinary system, okay? These are visceral sensory receptive sensory ones that are coming in. Then we have senses associated only with cranial nerves that are special, okay? That are special. And we have two types of sensations that are special. We have special somatic afferent, which is associated with some of these significant receptors, such as the eye, the retina surface, the vision, hearing, cranial nerve number 8, hearing and equilibrium, okay, are associated. And even we'll talk about when we get to cranial nerves, you can even consider the olfactory nerve to also be considered something like this. It's called special somatic afferent. These are nerves that allow us to recognize things in our environment either visually through the sense of hearing and moving through equilibrium, or the sense of smell that we need to know to move safely through our environment, to basically, if nothing else, find our home, okay? Find where we live, okay? Then there are sensations that are once again associated with visceral tubular entities. These are special visceral afferent, okay? And I'm going to write some of this down in a second, all right? So those special visceral afferent are coming from receptors that monitor really two types of special visceral sensation. in the nasal cavity, the beginning of the respiratory tract, hence a visceral tubular organ, the sense of smell. Or in the oral cavity, coming from little receptors referred to as taste buds, the sense of taste. Okay? Once again, the oral cavity is the beginning of the digestive tract or a visceral tubular entity. So these are special sensations. Now, there is not per se a special motor activity outside of the head. And that's because what's special in the head is where, you haven't had Dr. Farrell yet, have you? The embryologist? You had it, but you haven't had it for this. No, okay. All right, so he's going to talk about these entities referred to as branchial arches, gill arches. And what comes from gill arches are structures associated with the mechanisms for breathing and feeding associated with animal forms, okay? Whether it's simple vertebrates that swim, okay? Or whether it's more complex vertebrates like primates, okay? Which chew, okay? And breathe, okay? They breathe through their nose, they chew with musculature associated with their jaws, okay? So this is actually considered to be a visceral motor entity, okay? So we'll write some of this down, okay? And we'll talk about it in greater detail when we get to the cranial lecture, which I think is after this. So the only place there are special sensations or special motor activities in the head associated with cranial nerves. There's no other special activities associated with any other part of the body, okay, whether it's sensory or whether it's motor. I tell us to the podiatry students, I said your feet can smell, but you can't smell with your feet. Okay, I thought it fit in. So we have this sensation here, the optic nerve, okay? That's going to be in the orbit. Oh, yeah. Okay. Let me just rotate this. It's probably okay, so this is Tuesday, this isn't Monday, is it? All right, so this is a special sensation, special somatic afferent, okay? This is the sense of vision, okay? This is the sense of vision. We need to see in our environment in order to get around in our environment, okay? Now, the ocular motor nerve, the third cranial nerve, which is in this region, okay? That has three different components associated with it, okay? Three different fiber bundles that are associated with a different type of nervous system activity. GSE is motor, okay? This is general somatic efferent. And then it also has GSA, which is a sensory component, afferent. Afferent. Okay, so general somatic efferent, the oculomotor nerve, oculomotor, it's associated with some internal aspect of vision in accommodation of near vision, actually. Pupillary constriction, changing of the thickness of the lens. But it is also associated with the movement of the globe of the eye inside the orbit. These are skeletal muscles. They came from somites, like other somites in the other parts of the body. Okay? The other thing it has here is it has this GVE component, which is general visceral efferent. Now, I think I told you this before. General visceral efferent is synonymous with what part of the nervous system? General visceral efferent. This is motor. This is motor to visceral structures. What part of the nervous system specifically innervates things like smooth muscle, glandular smooth muscle, and cardiac muscle? Autonomic. So GVE is synonymous with autonomic. The oculomotor nerve, we talked about this, I remember, is the highest parasympathetic cranial nerve. How many cranial nerves have parasympathetic output? Okay, 4, right? The oculomotor, cranial nerve number 3. What's the next one? The facial, cranial nerve number 7. What's the next one?
Oh, what's the facial's autonomic responsibility?
Secretomotor, mucosal glands. Okay. Okay, what's the next one?
Vagus.
All vagus is the 4th one. What's before the vagus? Glossopharyngeal, cranial nerve number 9. Okay. The glossopharyngeal nerve, from a secretomotor perspective, innervates, if nothing else, it innervates the parotid nerve. Okay. Vagus nerve is all over the place. Okay. Vagus nerve is all over the place. That's the upper portion of the autonomic nervous system we refer to as parasympathetic. Okay. So then we have another cranial nerve in here that has a couple of components. One is the trochlear nerve. Okay, it has GSE, just like the oculomotor had GSE, and it has GSA. Okay, now these GSA components are interesting because one of the things that's sometimes left out of cranial nerve charts or cranial nerve discussions, at least in anatomy tests, is the fact that all skeletal muscles send back afferent information associated with the contraction activity, the tension activity of those muscles. What are they doing? What are they doing? Okay? And this is proprioception. There are actually some authors are talking about creating a different component called GP, general proprioception, instead of just assuming that proprioception is a general somatic sensation. Okay? All right. So the trochlear nerve innervates a muscle we'll talk about when we talk specifically about the eye, referred to as the superior orbital oblique. Okay? But it does not have any autonomic fibers, just general sensory and general motor to the skeletal muscle. Then the trigeminal that runs through here, this is the trigeminal, this is V sub 1, this is the ophthalmic branch, okay? And the ophthalmic branch branches into a few branches, okay? And here's what you have to know about the trigeminal. Other than the 3rd division, the mandibular division, okay? The 1st division, the ophthalmic, and the 2nd division, the maxillary, only are general sensory. Only are general sensory. Okay? And that itself is a huge distribution to the face, the teeth, the oral cavity, the nasal cavity, and so on and so forth. Okay?
Which two are those again?
the ophthalmic division and the maxillary division, V1 and V2. V3 has motor. What's the motor to? Muscles of mastication. Muscles of mastication. What are those muscles of mastication? Medial and lateral pterygoid, right? Is anything else innervated? Yes, but don't worry about it right now. Okay, so all of these branches from the ophthalmic, and we'll talk about the maxillary, these are GSA, general somatic afferent, okay? So primary branches are the frontal, the lacrimal, and the nasociliary. Okay, we'll talk about these as we go on this afternoon, okay? These are all general sensory, okay? Touch, pressure, pain, temperature, and proprioception. That's GSA. We'll talk about these in great detail when we get to the cranial nerves themselves. Okay? All right, then we have maxillary branches that actually flow through the floor of the orbit. Okay, so they have an orbital relationship. They flow through the floor of the orbit from back to front from this space called the pterygopalatine fossa, where they have branched from the main maxillary trunk that has come in through foramen rotundum into this space. Okay, so the main branches here are branches such as the zygomatic and the infraorbital. Now these are just branches that are traveling through the orbit. Okay, these are just branches traveling through the orbit. These are GSA. Okay, so remember I showed you a couple hours ago that there were openings in the zygomatic bone called zygomaticofacial and zygomaticotemporal foramen. They are actually transmitting sensory branches from the cheek and the lateral scalp back into this zygomatic branch of the maxillary division. These are general sensations from the face and lateral scalp. Okay. The abducens nerve is just like the trochlear. It has GSE and GSA. Once again, GSA is because the muscle that this nerve innervates comes from somites, okay? All muscles that are GSE come from somites. Most of the muscles, other than the head, that are skeletal come from somites. Do you get a lot of robocalls? Have you found a way, besides going in and blocking every darn call that comes in? And then,
Certainly there are apps you can
huh?
use.
Well, send me that, reference to that now. Okay, because whatever I'm doing now does not work. They rotate either the prefixes or the suffixes of the phone numbers, and each one must have 1,000 different prefixes or suffixes. And I don't know, based upon supposedly what the do not call list was supposed to stop, how they have kind of ignored that or just got so frustrated themselves they can't deal with it. But I get these all day. I get one actually that comes across AT&T spam. And I'm saying, you know, why can't you, you're my carrier, why can't you just block this? Drives me nuts. I'm sorry. I'm venting. Okay, so then also branches of another cranial nerve come through here, which is cranial nerve 7, the facial nerve. And the facial nerve, once again, is associated with parasympathetic output, general visceral efferent output, okay? Now what we'll find is interesting how the facial nerve relates to this is that the facial nerve has an interesting relationship with the maxillary nerve. Okay? We'll talk about this, probably not so much now, but maybe we'll get to the deep face or into the pharynx. Because what happens, all autonomics the autonomic nervous system is what? Is it a single neuron system, or is it a two neuron system? Two, preganglionic neuron in the central nervous system, a postganglionic neuron somewhere outside in a ganglia, in a peripheral aggregation of neurons, okay? So it's a two neuron system. We know it's only motor. It's only visceral motor, okay? The facial nerve in the head has a huge visceral motor distribution to things such as mucosa, the nasal mucosa, the upper pharyngeal mucosa, okay? The lacrimal gland, okay? The palatal mucosa, the mucosa in the floor of the mouth, the submandibular gland, the sublingual gland, okay? It has a huge distribution. And it also has an interesting relationship to the trigeminal nerve, both to the second division and the third division. The second division acts as a carrier now for post-ganglionic parasympathetic fibers coming to a ganglion, once again in the pterygopalatine fossa called the pterygopalatine ganglion. All of that greater petrosal branch I talked about, synapses there. All of its postganglionics come from that ganglion in the fossa and are distributed to the same tissues or the same places the maxillary nerve receives its general sensation from. And that makes sense, okay? There's a lot of things about the body when you look at it and say, you know, this was very well thought out. You know, this was very well thought out because these are sensory areas that are coming from mucosa that is a secreting surface that needs motor innervation of these mucosal cells, of these goblet cells, and things like that. So wherever the trigeminal maxillary division goes, so does a postganglionic parasympathetic fiber from the facial nerve. Okay, we'll talk about this over and over again, where these are coming from, how they are traveling. Okay. So the facial nerve here, the components associated passing through the orbit, because we've got this lacrimal branch, is autonomic, is secretomotor fibers, basically, to the lacrimal. Okay. And we'll talk a little bit about how they get there. The other thing is that the facial nerve also has a relationship with another one of its branches that comes through this petrotympanic fissure from the middle ear chamber and goes through that laceration, that petrotympanic fissure, and joins a branch of the mandibular division called the lingual nerve. And that's the chorda tympanic branch, yes.
So there are all these very small foramina and fissures. If during development, for whatever reason, one of these very small apertures didn't form, would the nerve just never reach?
Yeah.
Okay.
Or it would have to get there some other way. It would have, you know, developmentally, it would have to have some kind of way
So
of
as the
figuring it
biggest
out.
grows,
Sometimes,
you've gotta
sometimes that happens, but typically, probably, I guess, using the rule of 9 out of 10 times, it's probably gonna get to where it's going from the typical way that it travels. But there are some times, or it doesn't happen at all. That tissue doesn't get sensory innervation, okay? Something like that. There's a disease called Kalman syndrome, lack of development of olfactory receptors. So these are individuals that have no sense of smell. So this is believed to be a genetically transmitted type of disease problem.
Do they have sense of taste if they don't have sense of smell?
They usually have taste, but they don't have smell. And when we talk about that actually in neuro, taste and smell are closely linked. What smell supposedly gives us in relationship to taste is this concept of flavor. The things that we're putting in our oral cavity. What is this flavor, or what do we attribute this flavor to? And that is combining taste receptor information with smell receptor information up here, okay, in the brain. Okay, so, I don't think have we looked at this before? I can't remember, I'm always throwing brains around, but, so we've got two nerves that we're really gonna look at. Today we're gonna look at, this nerve over here. This is cranial nerve number 5. This is the trigeminal. And this is the trigeminal trunk that is coming and going from this area here, which is referred to as the pons. Pons is a huge area of nuclei, of neuron populations that are central nervous system in position, okay? The trigeminal trunk has two parts to it. It has a large GSA trunk, sensory, and it has a smaller SVE trunk. These are going to muscles that develop from branchial arches, hence special visceral efferent. No other skeletal muscle in the body is innervated by cranial nerves, okay? Just these branchial arch muscles associated with the first branchial arch, 5, second branchial arch, 7, the third glossopharyngeal, 5th and 6th, the vagus, okay? So supposedly, I'm sorry, 4th and 6th, the vagus. The 5th supposedly gets incorporated into the cardiorespiratory system, whatever structure is there, okay? So these are structures that are now going to travel through some of these openings we talked about, okay? So here, the optic nerve is going to go through this. This is the optic canal. And that will transport, from a nerve perspective, transport cranial nerve number 2, the optic nerve, okay? This opening alongside, underneath this bone, this coming across here, okay, coming out here, and here, and here. This is the lesser wing of the sphenoid bone. So the optic canal is in the sphenoid bone, okay? Next to it is this opening here. This is the superior orbital fissure. And the superior orbital fissure, what is going to go through there is cranial nerve number 3, the oculomotor, cranial nerve number 4, the trochlear, cranial nerve number 6, the abducent, and V sub 1, the ophthalmic division of the trigeminal nerve, are going to go to the orbit by entering through the superior orbital fissure. If we go down here, this opening, this opening is the foramen rotunda. What goes through the foramen rotunda? Which division? V sub 2, the maxillary division. Okay, so V sub 2. Okay. And then if we go back a little bit further, we get to this oval shaped foramen. This is the foramen ovale, and this is where V sub 3 comes from. All 3 divisions of the trigeminal nerve pass through openings in the sphenoid bone. All three divisions of the trigeminal nerve pass through openings in the sphenoid bone. Superior orbital fissure, V sub 1, the ophthalmic, foramen rotundum, V sub 2, the maxillary, foramen ovale, V sub 3, mandibular, okay? All three divisions pass through the area of the sphenoid bone, through openings in the sphenoid bone. Okay, so here we see this relationship of these nerves. Before Rowan got involved with just photographic illustrations, he had written a textbook, and this is one of the illustrations out of his first textbook. So here's the optic. Over here, this is ocular motor. Here is trochlear. Here is abducent. And here is V sub 1, the ophthalmic. And then here, this is foramen rotundum. This is V sub 2, coming through here. Here, by the way, looking in here, this opening is what I was talking about, that is receiving autonomic branches from the middle cranial fossa. This is the posterior opening of the pterygoid canal or Vidian canal. Okay, and this is the sphenoid sinus. What's this? What's this? Sitting on the top of the sphenoid bone. Pituitary. That's hypophysis, that's pituitary, sitting on an area referred to as the soletriska, the Turkish saddle, okay, on top of the sphenoid bone, okay. That sinus is just below the sphenoid bone. You can get pituitary tumors that break through the sphenoid bone and into the sphenoid sinus and wind up going into the nose, nasal cavity, or you can have tumors from the pharynx breaking through the sphenoid sinus and going up into the middle cranial fossa adjacent to the hypophysis. Okay. Now, then we've got this blue for venous structure here on each side. This is referred to as the cavernous sinus. Okay. So this term sinus gets thrown around loosely. We've got sinuses that are air sinuses. Maxillary sinus, frontal sinus, okay, sphenoid sinus, ethmoidal air cells, okay, maxillary sinus, okay. These are air sinuses lined with mucosa. Okay. Then we have sinuses that are referred to as being dural sinuses. They are encased in dura mater. They flow through encased dura mater as a venous channel, but they do not have the same internal histology as a vein. So this sinus sits in an area that is a depression on the side of the sphenoid bone, down below the pituitary, over in here, or in here. And this depression has on its outer surface, it has a sensory ganglion associated with the trigeminal nerve. And that sensory ganglion is referred to as the trigeminal ganglion. And as the trigeminal ganglion grows and forms, it creates or enhances this depression. So this depression is called a cave. And so it's called the trigeminal cave. So this venous sinus sits on the outside of the trigeminal ganglion, and since it sits outside the trigeminal ganglion, which sits in the trigeminal cave, it's called the cavernous sinus. Okay? Once again, there's no magic about anatomy. It really kind of makes sense. Okay? You just have to know the language, just like any other language. Okay? So this is where the cavernous sinus lies. Now, an interesting thing about this sinus over here in particular is some of these cranial nerves in particular run alongside it. For example, here we have the trigeminal, and then we've got the oculomotor and the trochlear. But over here, running through this, actually adjacent to this artery that also runs through it, this is the internal carotid, by the way. This is cranial nerve number 6, the abducen. Okay? Now, when arteries get inflamed, it creates an arteritis, which is kind of dangerous in its own way. When veins get inflamed, they create like scabs on their inner surface that are called thrombi. And these thrombi can, if the inflammation doesn't go away, they can cause blockage of the vessel or things like that. But if a vein gets inflamed, if there's anything associated adjacent to this venous channel, it can be affected by the inflammatory process. In this case, sometimes there's swelling in those venous channels that actually compress the abducent nerve. Okay? The abducent nerve innervates an extraocular muscle called the lateral rectus that abducts the eye, pulls it out temporally. That's how it gets its name. Okay. So if you have an inflammatory process that affects this sinus, for whatever reason, a lot of the reasons, to be honest with you, is because an inflammatory process comes from the face and flows back through the orbit in here. Then the person, if they move their eye in a given direction, they get double vision. Because in human primates in particular, they have what we refer to as stereoscopic vision. Both of their eyes have to work together simultaneously in order for us to see clearly. If one eye is off, when you move in the direction of that affected eye, you start to see two objects. You start to get double vision. So this sometimes is a key to a condition that's referred to as cavernous sinus thrombosis. Where does it come from? Well, we'll see on the face as we move through here that there is a venous tributary of the face that actually joins venous tributaries of the orbit, which actually, the other thing coming through the superior orbital fissure, other than nerves, is the ophthalmic vein. Where does it drain? Into the cavernous sinus. So facial infections in here can cause a retrograde infection because, once again, there are no valves in these veins. It can flow back into the cranial vault. It can cause a thrombotic type of inflammatory process in the trigeminal cave, or in the trigeminal cavernous sinus. Also, it can cause irritation of trigeminal ganglia, but it leads to this double vision. So, interestingly enough, the other thing that happens here is that typically with a patient that has this cavernous sinus thrombosis, they do not have a typical type of inflammatory process that you might see in their throats or their pharynx, their oral cavity, that would lead to something like pharyngitis or laryngitis or something like that. And so if you don't see that, but they may spike a fever of 105 degrees Fahrenheit or 39 degrees Celsius, you start to look at their facial skin to see if that's it. Okay. And probably if they are like pubescent or prepubescent, that's probably what's going on. Because what are they doing? They're not listening to their parents or their physician, and they're picking at those zits. Okay? And those zits are getting inflamed, and they're getting infected. What kind of bacteria is on skin? One in particular. Staph. A very virulent bacteria. You get staph back into your brain case and you got serious problems. Okay? So these bacteria flow back, cause a cavernous sinus thrombosis. This causes an inflammatory process. What's sitting above the pituitary? The floor of the brain. What sits above the pituitary? Hypothalamus. Does the hypothalamus have anything to do with our temperature? Okay, so all of a sudden the hypothalamus is getting these mixed signals, and all of a sudden your core temperature goes up to 100, 105, 106 degrees. So it's a dangerous situation, but it's also a typical situation that typically happens in relationship to this inflammatory process, and can be determined or at least thought about from the standpoint if you've got a patient and you ask them to follow their eye, in particular if their eye, this, let's say over on the right side, this nerve has been obtunded, it's been compressed, and you can't abduct the eye over here, but the eye over here is moving, then you have a double vision situation. So that's kind of a key factor in cavernous sinus thrombosis. Once again, with venous channels associated not only with the middle cranial fossa, but with the orbit itself. Okay, why don't you take a break? And you can probably leave and go study here. And we've got here our trigeminal ganglion. Here's the trigeminal ganglion sitting against the trigeminal cave. The cavernous sinus has been basically cut away. And here you have the first division, the ophthalmic division. Here you have the second division going through foramen magnum. So this first division is going through superior orbital fissure. You have the third division going through foramen ovale, and then this is the trunk of the trigeminal nerve that is attached to the brainstem, it's attached to the pons. Okay? So has both sensory and motor in it. The only type of neuron cell bodies that are in this ganglion are sensory. The motor fibers that are leaving with this branch are passing through the ganglion. They have nothing to do with cells in the ganglion. What's in the ganglion are GSA type cells, sensory, general sensory cells.
Can you point out the trigeminal trunk again? Is it the entire thing? Just that part?
Just that. When we see it, when we take the brains out, we see it in the lab, okay? You can't, it's hard to see it because that particular portion, all of this is covered with dura mater. Okay? All of this is covered with dura mater. So we have to actually dig under the dura mater to see it. Dura mater is a meningeal tissue. It is a very thick, tough division. As a matter of fact, the term dura literally defined, dura mater means tough mother.
Wait, what's the difference between a trigeminal trunk and then a trigeminal ganglion?
The ganglion is a peripheral aggregation of neuron cell bodies outside the central nervous system. The trunk is interconnecting the trigeminal nerve with the central nervous system. So those sensory cells are going to send information into the pons, into the central nervous system, to be interpreted in regards to the type of sensations that they are. You know what a posterior root ganglion is? We talked about that last day. So trigeminal ganglion is just like a huge posterior root ganglion. Sensory cell bodies just receives sensory information. There's no motor in there. And it's taking that sensory through the trunk back to the pons. There's a separate tiny little branch of this, it kind of shows it right here, passing deep to this main trunk that passes through the ganglion and leaves through the foraminal valley with the third division, becoming part of the mandibular division, which is going to become muscular branches to the muscles of mastication. But in that ganglion are only GSA, okay? So this is only GSA, basically general sensory. Okay. Here's another look at it. Here it is showing it interconnected, okay, to the pons. Here's the pons. This is passing under the dura. Here's the ganglion over here. Here is the ophthalmic division. Here is the maxillary division. Here is the mandibular division. These little rootlets here, trigeminal nerve actually receives sensory information from the surface of the dura intracranially, the cranial floor that the brain is lying. Okay. Here, this branch here is not associated with trigeminal. This is actually coming. This is the underside of the pons. This is coming from the back area of the brainstem. This is the trochlear nerve. Trochlear nerve is the only cranial nerve that comes off of cranial nerve 4. It's the only cranial nerve that comes off of the posterior surface of the brainstem. Okay. So that's not trigeminal. Okay. This is trochlear. Cranial nerve number 4. Okay, so the ophthalmic division of the trigeminal nerve has these branches. What the stars or the asterisks imply is all of these branches are general sensory. All of them are GSA. Okay? So lacrimal branch, frontal branch. Frontal branch has 2 sub-branches that come to it called supraorbital, supratrochlear. Then there is a more medial branch called nasociliary. That medial, winds up medial to the optic nerve, that has a posterior ethmoidal branch and an anterior ethmoidal branch. And then there is a branch that leaves the orbit, and it goes under a structure we'll talk about in a couple minutes called the trochlea, and it travels deep to the trochlea. And then these long ciliary nerves are given off to the back of the eyeball. To the back of the eyeball. These are actually mixed nerves. Some of them are trigeminal, some of them are autonomic sympathetics. So these are also here, GSA, but also GVE, and now not parasympathetic, but sympathetic. And they get there because the ophthalmic artery comes into the orbit through the optic foramen, and on its surface are these postganglionic branches of sympathetic nerves. And what's sympathetically in the eye? Do you know what's innervated sympathetically or parasympathetically in the eye? That move the globe? No. What other muscles are there? Okay. Well, the retina's not a muscle. Okay. Huh? Sclera is, in the front of it's cornea. So that's the sensory, the sclera and the cornea. The corneal reflex is actually part trigeminal reflex. Huh? There you go. Okay, the iris. Now, what can the iris do? Is the iris always at one dimension?
No, it expands and contracts.
Okay, what do we call that? When we've got an opening that expands, we say that it either constricts or it dilates, okay? So, what would cause it to dilate? What part of the nervous system? What's stress? What is stress do? What's the most common stress that we have? No, that's only second. If you had to take your exam in the dark, that would be the primary stress. Okay? So, what happens when we go into a dark space? What do our eyes do? What do our pupils do? They open as wide as they can because trying to get whatever waves of light they possibly can to see, whether it's just the shape of an object, but to see it. So pupils dilate sympathetically. So these long ciliaries carry these sympathetics to the dilators of the pupil. They're called radial muscles. They're like spokes. Okay? The parasympathetic system is brought there via this first parasympathetic branch, the ocular motor, and it has two smooth muscle entities that it innervates. One of them is wrapped around, circles the lens of the eye, and it's called the ciliary body or the ciliary muscle. And the other is the muscles in the center of the pupil that when they constrict the pupil, when they are activated, the pupils constrict. Okay? Most of the time our pupils are somewhere between dilation and constriction. We can use a little light and take it a long way to see, okay? But we can't, when we're in a dark environment, we're kind of stuck for light, okay? So we have to open up that pupil, okay? So constriction of the pupil, that's ocular motor nerve, but what is happening to this circular muscle around the lens? It's like a big ring, a ring sphincter, and hanging from it are little, tiny little ligaments attached to the surface of the lens. They're called zonual ligaments, okay? And when this muscle is relaxed, it's expanded. It's an expanded ring, and it puts tension on those ligaments, and the lens is actually fairly thin from back to front. But if we're put in a situation where we have to see things that are coming close to us, because even though this outer cornea is our main refractive surface, our fine tuner is the lens. And as something comes close to us, what are we doing? We're blocking out the light. Where's the light? It's over here, it's over here, it's over here. So now we've got to bend that light, and we need a thicker lens, a more robust lens to front to back to bend that light and focus it on the retina. Okay? So what is happening here from the standpoint of parasympathetics is this is called accommodation to near vision. Our ability to bend the light and see objects as they're coming close to us and blocking out the light, and actually see these objects that are very close to our eye. And we're actually focusing down on closing down on the pupil because we're trying to concentrate the light that's going back there to hit the retina. Okay, so this is called accommodation of near vision, yes.
So the parasympathetic portion that you just described, is that a subset of the long ciliary?
Sympathetic is. The sympathetic that innervates the dilator.
So what's the parasympathetic?
That's portions of the ocular motor nerve that are parasympathetic.
So how do drugs affect the dilation of the pupil?
Well, I guess you can take them and find out, but I mean, you've got opiates that will artificially, well, not artificially, they will cause a dilation of the pupil, a dilated pupil if you're high on opiates. And cocaine, though, which is actually a local anesthetic, but it's a constrictor. Cocaine causes vascular constriction, it causes causes pupillary constriction. So people that are on drugs like cocaine are gonna appear with a constricted, probably constricted. Okay. Also, constricted pupil usually, in somebody who's not moving around or anything like that, usually implies that they're dying. Okay.
But why? Like, is that a sympathetic?
Because one of the things that cocaine does is cause vascular constriction when you start to close, when you hit in the body, when you start to reduce blood flow to organs, that's death. Okay, that's death of the organ and eventually death of you. Okay, cocaine does it right away. Actually, I'm wondering what they're gonna use a left acid dye. But it's, because I have, on the other side, I had needle lens procedure. And usually they use cocaine as an anesthetic, okay, to the corneal surface, to ophthalmologists do that. So, it's the only vasoconstricting anesthetic, local anesthetic. All the other local anesthetics are vasodilators. So if you get high on local anesthetics, you will have probably have a dilated pupil. But also you will have hypertension and your heart will give out and you'll die. Okay, so Dr. Terzan, I don't know if you get some farm, I think next semester, don't you? You have some farm next semester? From the farm PhDs. And then Dr. Terzani comes in your junior year and he goes through and talks about drugs that your patients take, which is actually a good lecture. Okay. Okay, so all of these divisions are primarily sensory, okay? As they're passing through the orbit, they are coming from skin, okay? So regionally, we can divide the surface of the face into thirds. To this area here, okay, and into this area here, and so this is V sub 1, this is V sub 2, and this is V sub 3. What about this? What innervates that? Okay, what is that? What innervates this? This is innervated by the cervical plexus. This is innervated by C2 and C3. Okay? Do you know anything else that had a relationship to C3? Diaphragm, okay. And that was innervated by what nerve? Phrenic nerve, okay. And is the phrenic nerve just motor, or is it motor and sensory? It's motor and sensory. So sometimes things can be referred from the area of the diaphragm or the thorax, pericardial sac, or things like that, referred up to your jaw, or your patient's jaw. And not be associated with tooth pain, but be associated with possibly a myocardial infarction. Okay? So all of this back here is cervical plexus. For the most part. Okay? All right, so let's look at these nerves as they travel through the orbit. Here we have here are your extraocular muscles. That's what the muscles here. This is a muscle called levator palpebrae superioris. Okay, this is where anatomy lingo. What's a palpebral fold? What's a palpebral fold? Your eyelids, okay? So, levator palpebrae superioris. What's it doing?
It's opening the eyelid.
It's lifting the upper eyelid. It's lifting the upper eyelid. Okay. It has an interesting relationship from an autonomic perspective as well. Okay. So then over here we've got this muscle called the superior oblique. And this is innervated actually by this little nerve twig here, coming onto the top of it. And this is cranial nerve number 4, the trochlear. Over here, we've got a couple of nerves. One, we can't see the one that innervates the muscle, but we can see this nerve coming over here, traveling over the top of the muscle, traveling over here, actually passing by this little glandular structure over here. This is the lacrimal gland. And this is the lacrimal branch of V1. This is of V sub 1. Here, coming over the top of levator palpebrae, is the largest branch of the ophthalmic, and this is referred to as the frontal branch. Frontal will actually have this large branch here, which we refer to as supraorbital, and a smaller branch here that is referred to as supratrochlear. Okay, so this lacrimal branch is interesting. We'll talk about it when we get to the maxillary aspect of the trigeminal. But all of these branches are general sensory branches. They are receiving general sensation, not the trochlear, that's innervating the superior oblique, but the lacrimal and the frontal are receiving sensory feedback from your scalp as far back as the vertex, your peak of your scalp, okay, your skull, and from the lateral corner of your upper eyelid and the skin over the lateral portion of your palpebral folds, both upper and lower. It's receiving that sensation. We'll talk about how the lacrimal gland gets innervated in a few minutes. Hopefully we'll get there. Okay, but the motor innervation actually is autonomic, so it gets there kind of a indirect way. Yes.
You know how sometimes they say sleep deprivation or certain causes like twitching of the eyelid? What's that all about?
Well, when we put the autonomic nervous system in a general perspective, what did we say? We said that parasympathetic was homeostasis, homeostatic activities. Right? What was sympathetic? Stress. Stress. The levator palpebrae superioris has 2 types of innervation. It is skeletal muscle, and it has an innervation from cranial nerve 3, the oculomotor, but there's some small little smooth muscles in its area as it attaches to the palpebral fold that are smooth muscle, and they are innervated by the sympathetic nervous system. So when you're stressed, some things happen, okay? Like, you've been studying all night, and you're trying to keep your eyes open, and you're stressed, and you're pulling back on your upper eyelids as much as you possibly can, and those muscles are getting fatigued, okay? And they start to cause fasciculations, cause that type of activity. However, another thing that they can do is that, this is far from the age of what I call Class B movies, where the actor either had to create the emotions, create the activity, or they used some type of pseudo, superimposition of these images. Like Godzilla, all you needed was a large picture of a city, and you just put Godzilla in there, and walking through the city. Now, Godzilla's a lot better than that. I mean, this is a souped up Godzilla. But you had to show fear. How do you show fear, okay? One of the ways you show fear is by opening your eyes wide because you are stressed, okay? Fear is stress, okay? Dental school is stress. Studying 12 to 14 hours a day is stress. Okay, here's looking at it from an anatomical perspective, from a gross anatomy perspective. Okay, here, this is this levator palpebrae superioris. Underneath that is another muscle, this SR, that superior rectus. It's a straight muscle. Over here, here's the superior oblique, innervated, once again, by the trochlear nerve, coming over here. And all of this stuff in here is fat. The eyeball is surrounded in its compartment with fat fat is serving as a mechanism to kind of, take this space and make it more compact. But from the same standpoint, here we got this large connective tissue ball that is constantly moving as we look at things in our environment, and we'd like it to move without being, kind of rubbing against things that are hard, that can cause it to become, the outer surface to become inflamed or scratched. So this fat acts as a lubricant. The eyeball actually, as a joint, the eyeball actually articulates on what we call this periorbital fat. Okay, it articulates on this periorbital fat. So that's what all of this fat in here that's surrounding these muscles. And this nerve, this large frontal nerve, they're not showing the break in the supratrochlear. They are showing the lacrimal branch over here, and the frontal branch over here. Okay?
What is LPS again?
What is, what?
Oh,
LPS, levator palpebrae superioris. Okay. All right, so now we see these fibers again as they're running through here, and we have the blood vessels also in here. This is the ophthalmic artery running through here. Okay, so this is ophthalmic artery. And we see these nerves associated with the trigeminal. We see this lacrimal. Frontal's been cut away. We actually see some nerves that are referred to as being ciliary. These are short ciliary. These are associated with the oculomotor nerve. They're actually carrying parasympathetic fibers. And then over here we've got a nerve branch of the V1 division running parallel to the artery, and this is referred to as the nasociliary. It actually has some ciliary fibers going to the back of the eyeball, and these are called long ciliary. And then the nasociliary is going to give off some branches into the nasal region, lateral and out medial to it. And these are called ethmoidal branches. This is posterior ethmoidal. And this is anterior ethmoidal. And then this one goes under, superior oblique has an interesting relationship to the eye. It goes down the medial side of the globe of the eye, and it gets to what's called a ligamentous pulley or a trochlea, okay? And it then loops back through that trochlea onto the top of the eyeball. And when it rotates the eyeball down and out. And so it does this because of this relationship with this anatomical pulley called the trochlea. And that's why they call this nerve that innervates it the trochlea, okay? So this branch of nasociliary is called the infratrochlear. Because it passes deep to the trochlea and actually comes out to the lateral side of the bridge of your nose. Okay, so here are these ethmoidal branches coming off of nasociliary over here. Here is a posterior ethmoidal back here, and here is an anterior ethmoidal. And this nerve will go into this area surrounded by your external nose, and we call the vestibule of the nose, that is going to be sensory to the inside of the mucosa that is inside basically your proboscis, your nose, okay? And that is the anterior ethmoidal. These little bubble-like regions that are adjacent to these nerves as they cross them are also air sinuses. They are called ethmoidal air cells. Okay? These are called ethmoidal air cells. Okay, so the nasociliary is coming in here on the medial side to give off these component parts. Okay? Now, this portion that goes from the anterior ethmoidal into the vestibule is called this anterior ethmoidal is called the internal nasal. Okay, the internal nasal. Now, when you get into the lab, we've got this little tiny bone box, and there's some nasal bones in there. And on the outside of a nasal bone, where you can see this on your skulls, there is a little tiny foramen. And that nerve that comes there is a branch of this anterior ethmoidal that pierces the nasal bone, comes out to the bridge of the nose. Have you ever gotten hit on the bridge of your nose? Okay. That, for a tiny little nerve, it can, it can draw you to tears. It can draw you to tears. Yeah, you're soccer, right?
Yeah, I got in there so many times.
Okay. All right, so this is the external nasal. It goes to the skin or the bridge of the nose. If we look at here, now once again, here is the lateral rectus. Here is the lacrimal nerve, which is going to go over the top of the lacrimal gland and go outside. And then over here, here's the oculomotor nerve coming over here. And if you look at here, there's a little enlargement. What is that? And there's some fibers coming to the back of the eye, these short ciliaries. What is that enlargement? Does the oculomotor nerve have an autonomic relationship? Okay. It's the highest parasympathetic nerve in the head, actually in the body. So, two-neuron system. This is called the ciliary ganglion. And these are short ciliary or postganglionic ocular motor fibers. Here, once again, is the nasociliary over here, and the ophthalmic artery. Nasociliary coming back here as well, okay? So, and then with the muscles off at the top of the globe of the eye, we can see the optic nerve, cranial nerve number 2. In here, okay? All right, so these are branches of V1 that are only sensory. The ocular motor is not a V1 branch, it is a separate cranial nerve. The trochlear is not a V1 branch, it's a separate cranial nerve. And the ocular motor is innervating, typically innervates all but 2 muscles, what we call extraocular muscles outside the globe of the eye, because the trochlear innervates superior oblique, and the abducent innervates the lateral rectus. But a large portion of levator palpebrae superioris is innervated by it. The superior rectus, the inferior rectus, okay, the medial rectus, and the inferior rectus are all inferior oblique are all innervated by ocular motor nerve, okay? There are 7 extraocular muscles. The other 2 are innervated by trochlear and abducent. So we'll, once again, like I said, there's a lot of repetition that we do in here in relationship to this region. One of the repetitive areas is going to be the orbit. All right, let's talk a little bit about how the maxillary nerve comes to play in here. Okay. All right, so here is, there's the foramen rotundum. So the maxillary nerve is going through the foramen rotundum from here. This is the ganglion. This is the trigeminal ganglion. We're coming to it, actually. And it is coming from this region here. This is the pterygopalatine fossa. Now, as I mentioned to you before, there are 2 nerves that approach the maxillary division medially, and one of them is a branch of the facial nerve, and that is coming here.
Can you repeat what the blue says?
The blue circle?
Yes. What fossa?
I'm sorry.
Sorry, it's making it out, it's very weird.
Pterygopalatine fossa. Okay. All right, so this green structure here came from the facial nerve. This is the greater petrosal. Then here is the carotid, internal carotid artery coming up here. And on its surface are going to be postganglionic sympathetics that are part of a nerve referred to as deep petrosal. These are postganglionic sympathetics. What's greater petrosal? Pre or post? Pre-ganglionic, right, okay? Now, they are going to enter into a deeper opening and travel through this opening as the nerve of the pterygoid canal. And greater petrosal is going to come here and synapse in a ganglion in the pterygopalatine fossa, which is hanging on the maxillary nerve trunk as it is leaving the pterygopalatine fossa, okay? So this ganglion, this ganglion is the pterygopalatine ganglion. And what's synapsing there is the greater petrosal branch of the facial nerve. And this ganglion is hanging on the maxillary division of the trigeminal nerve, okay? And the maxillary division, as I mentioned to you, receives, actually, because it's sensory, receives all of its branches in what space? This space, the pterygopalatine fossa, right here. All of the trigeminal maxillary division sensory branches are going to come back to this nerve trunk in this pterygopalatine fossa. However, hanging on here is this parasympathetic ganglion associated with the facial nerve greater petrosal branch. So all of the postganglionic cells of the greater petrosal branch, or the facial nerve here, are going to be in this ganglion. Now, are they sensory or motor? Both? Okay. There's some truth to the both, but not from the perspective we're talking about in this ganglion. Okay. They're motor. They're visceral motor. They're parasympathetic. Everywhere a maxillary sensory branch is coming from, a postganglionic parasympathetic branch is going to go to. So if it happens to be to the nasal chamber, if it happens to be to the gingiva of the upper mucosa of the upper jaw, if it happens to be to the pharynx, the upper throat, the sensory fibers are going to come to the maxillary division. The motor fibers are going to go from this ganglion, following the branches of the maxillary division to the same place. Okay? So that's kind of a very efficient way of doing that. The thing you've got to remember, we'll talk about certain anesthetic techniques when we're in the lab. If you are going to give what's called a division 2 block and anesthetize up here and into this pterygopalatine space and basically anesthetize an entire quadrant of the upper jaw with a single injection site, what have you also done? You've shut down the parasympathetic secretomotor fibers to all of these mucosal tissues, including the lacrimal gland. Okay? So your palate's going to get real dry. Your nose is going to get real dry. Your eye is going to get real dry. Okay? So because there's a union of these general sensory fibers from V2 as a carrying media for these general visceral fibers from the facial nerve, greater petrosal. Yes?
What is that red, in red?
That's the internal carotid artery. okay? You know, that's the internal carotid artery. This is the junction of the sympathetics and the parasympathetics, and they're becoming this nerve here. This is the nerve of the pterygoid canal. This is the median nerve. Okay. I should have used a different color. Okay. All right. So then from there are branches of this maxillary division that are coming forward now, or actually coming backward. I mean, you always have to think about that. I have to think about it myself, is that, you know, we talk about branches going through an opening, but how are they going through the opening? Are they going from deep to superficial, or are they going from superficial to deep? These are sensory branches. These are bringing information back through, from your face, back to the central nervous system, so that you can feel these areas of your face, okay? So, and from the same standpoint, visceral motor that's being carried, these same branches, is going from this deep ganglion, this pterygopalatine ganglion, following the same sensory branches, but going to innervate mucosal glands, or the lac of one. All right. So, let's see how that happens here. This is probably, because we don't really have to get into mandibular division now. But I'm gonna kind of erase this over here and move it a little further over. Okay, so this is the pterygo. So here is, sitting back here is the pterygopalatine fossa. And these two branches that are coming forward are a combination of an infraorbital nerve coming through the floor of the orbit and going back, okay? And a zygomatic nerve, which is joining it and going back. So this is the infraorbital branch. And this is the zygomatic branch. Okay, so infraorbital is receiving sensations from, you know, upper gingival, upper mucosal surfaces, adjacent, probably somewhere from the from the canine all the way back to first molar, from the buccal mucosal surface. The zygomatic branch is going into this opening on the side of the zygoma called zygomatico-orbital frame, okay? Okay, so this opening here is called zygomatico-orbital. And it goes inside there, and then it gives off or receives a branch from out here on the outside of the cheekbone, okay? What is that on the outside of the cheekbone? What is that branch called? What was that little opening that we saw in the lab? Zygomatico-facial, okay? So this over here is the zygomatico facial foramen. We can't see behind the zygoma. There's a branch called the zygomatico temporal that's getting skin back here along on the surface of your temporal bone. Okay. Now, an interesting thing happens here. The zygomatic branch has two options. It's option one, it has to receive sensory information from the skin of your cheek and the skin of your more lateral temporal skin surface, over your temporal bone, over the scamosal portion of your temporal bone. Also, we'll see there's actually a branch from the mandibular division that assists in this. Okay? So those are general sensory. But a small twig does not go into that zygomatico-orbital foramen. It stays out, and it runs. This is the lateral wall. The zygomatico-orbital foramen is in the lateral wall of the orbit. This zygomatic branch, which is sometimes referred to as the lacrimal branch, travels on the surface of the lateral wall of the orbit and actually joins its cousin, the lacrimal branch of the ophthalmic division. So this lacrimal branch of the ophthalmic division is strictly carrying postganglionic parasympathetic fibers from the pterygopalatine ganglion, and going to take those fibers, interconnect them with this lacrimal nerve branch from V1, and now as V1 travels over the top of the lacrimal gland and comes out here to innervate the skin, these fibers drop into the lacrimal gland and are motor to those acinar cells in the lacrimal gland and cause it to release tears over the cornea. So it's kind of a, you know, wild and crazy type relationship that the maxillary division of the trigeminal nerve has with these postganglionic parasympathetic fibers of the greater petrosal branch of the facial. But it's important to understand that. Now we'll also see it in the with the chorda tympani when you do a block anesthesia and you do a high block. You can get not only numbness of the dentition by the inferior alveolar branch, but you can also get numbness of the mucosal floor because of the lingual branch. You can also, because of numbness associated with the lingual branch, you will shut off taste sensation. Okay? You will shut off taste sensation. And you will shut off motor innervation of the submandibular gland and the sublingual gland. So, once again, the mouth will become dry. We don't, I've never, I went through dental school, I was always afraid to open my mouth. You can understand why. But things didn't make sense, okay? Why does the mouth get dry during a local anesthetic? Because you've not only had a sensory effect, you've had a visceral motor effect. You've shut down the visceral motor output to mucosa, okay, to salivary glands, okay? And you gotta be cognizant of that. The reason I say that is you'll find, when you start doing this stuff in the mouth, that because the tissue's so dry, it becomes very friable. So you're pushing your glove against this tissue, sometimes you can create surface ulcerations in the mucosa if you're not careful. And this is why you need the assistant there with that air-water syringe, both drying and wetting the tissues simultaneously to try and prevent that from happening, because you can do that. There were cases I remember in my own practice where, I wasn't paying enough attention to that, and the patient would call me and say, my gums are very sore, and I said, well, come back in, and it was because they were ulcerated because of the excess pressure during the anesthetic period. They weren't feeling it, but the tissues were. So, that's why we're here, okay? We got to try and put this anatomy together with your clinical practices so that when you are doing clinical practice, you are thinking about it. You're thinking about what you're doing here. You know, you're picking up every day of your life, you know, unless you're an orthodontist, although some orthodontists I know gave local anesthesia and you scared them to death. But you're using a vasoactive agent. You're using a vasoactive agent. You're using local anesthetic, which itself is a vasodilator, combined with a relatively powerful vasoconstrictor to try and hold the anesthetic in the tissue, soft tissue longer, you know, epinephrine. So you gotta think about that. These are not things that you want to inject into vessels. These are things you don't want to inject into vessels, okay? You can get numbness of the entire lower dentition if you inject directly into the inferior alveolar artery. Because you just shut off the blood supply to, you know, not only the dentition, but to the nerves at the apexes of the dentition. I mean, you gotta think about stuff like that. That's really what it's about, you know, is thinking about this. All right. A couple other slides here just show, we'll show this. Again, the maxillary nerves also has a relationship to the upper pharynx, your throat, coming through a medial opening from the pterygopalatine fossa called sphenopalatine foramen. It also has fibers that come from that branch is actually called sphenopalatine, that come forward to the lateral wall or the concha that are more lateral in position in the nasal cavity, that are called posterior nasal branches of the sphenopalatine. And then there is this branch called the nasopalatine branch, which comes down on each side of the nasal septum, drops down through the floor of the nasal cavity, and comes behind your maxillary incisors. Okay, this platinum mucosa, there's both from a sensory and a visceral motor perspective. Okay? And you got to be careful. I mean, that incisor papilla injection is the most painful injection you could give a patient. Okay, it'll get them to rise up out of that chair. Okay, but you don't need to go too far. If you go too far, you can go through the incisive foramen and into the nasal cavity, and when you inject, the patient will say, they'll start coughing, because as they're lying there, the anesthetic is dripping down their nasal cavity and into their pharynx. Okay? We unfortunately have also had some graduate students place implants into the nasal cavity through that opening. Okay? So there is a reason for this. Okay? There is a reason for this. And just try, you know, and put it in perspective. We are early in this course. We're going to be going over this stuff over and over and over again, and we're going to be seeing a lot of this stuff in the laboratory, so maybe then it will make more sense. I wasn't happy the way the skull lab works in that West lab, and I got to figure that out. That's really just, that camera sucks. Okay, it just really doesn't project well. And did they take away some screens? I thought there were more screens in there when we first set it up.
And like that. Would it be possible to make the skill lab more interactive, but like maybe if other
I've done that.
labs been-
I've done that in the past.
Because
You
it
know,
was.
and that's
a
a
lot of
good
the
idea.
time We couldn't see into
That's a
the
good idea.
paper either, so we
Oh.
had no idea what was going on.
That's a good idea.
Maybe like a worksheet to work through.
Right.
Right. That's fine.
And hearing a lot of the words. you know,
I have
yeah.
done it in this room, where we basically sat on the floor, because we couldn't use the lab, and I think it's a better way to do it. And I had some upperclassmen come in and assist with the groups. Okay. So, you know, thank you for that. I'm kind of sorry. But we will see the skull over and over and over.
So will we have a skill lab where we get the pieces, the individual pieces of the skulls to like look at and figure out, or? is
That large black box is always in the lab. You can't take it out of the lab. The small little clear plastic box also. But they are always in the lab, in the lower cabinet, underneath the glass cabinet that the skulls are in, okay? And you can go in there and look at it. I have a table in there we've got to clean off that you can use for picking it from. But you can go in there That lab's open from 6:30 in the morning till 11. Just go. But I will have some sessions where I will go over this stuff.
Okay. And will you let us know when you're gonna be here on Saturday?
Oh, yeah, absolutely. Absolutely. No, it's,